Well, good morning, everyone. I'm going to go ahead and get us started. I'm Dawn Johnston, and I'm the Director of Development for the Providence Brain and Spine Institute, and it's my pleasure to welcome you to today's presentation. Thank you for joining us. As a member of the Providence Foundations of Oregon team, I have the joy of working with Dr. Cohan to ensure that he and his team are able to continue their research efforts for many years to come. Several of you on the call today have supported Dr. Cohan's research, and we are so grateful for the investment you've made in this important work. Thank you. Our program format today is a bit different from last year for obvious reasons, when we were able to gather in person to hear Dr. Cohan speak. However, even though we can't be together, we are in this together, and I'm pleased to share with you that we have, it looks like we've got over 70 people on the call today, with many more registered, so this is wonderful. A couple of housekeeping items before we get started. We wanted to keep today's program brief since many of you spend a great deal of time on virtual calls already. Dr. Cohan has about 25 to 30 minutes of presentation with space for about 20 minutes for Q&A at the bottom of the program. To ask a question, please use the Q&A tab found at the bottom of your screen. You kind of have to move your arrow down if you're not familiar with Zoom, and a little Q&A tab will pop up. If you have difficulty with that, though, you're welcome to email me at dawn.johnston@providence.org, and you can see that on the screen right now. Because there are so many of you on the call today, we might not get to every question. But if we don't get to your question, we will follow up with you after the program. And if you do have a question after today's program, you're also welcome to shoot me an email. Today's program is being recorded, and we will be sharing the link to the recording with all of you in a follow-up email. So please be on the lookout for that. Now, I'd like to take just a few minutes to briefly introduce Dr. Cohan, who really needs no introduction, but here we go. So Dr. Cohan is the medical director for the Providence Multiple Sclerosis Center. He joined Providence in 2000 after 27 years with Georgetown University, where he served as professor of neurology and pharmacology and chairman of the neurology department. Dr. Cohan has been a principal investigator in numerous therapeutic trials that led to FDA approval, as well as being the initiating main investigator for BEST, the beta interferon early steroid trial, Switch 24, MRI detection of disease activity in clinically stable MS patients, and currently the genomic profile of MS patients treated with ocrelizumab. In 2001, Dr. Cohan started the MS Center, which now cares for 3,000 plus patients on an annual basis and has 5 full-time MS clinicians. It is the largest MS center in the Pacific Northwest and one of the largest in the country. Dr. Cohan is also the founder of the Pacific Northwest Multiple Sclerosis Registry Project and the co-founder of the National African Americans with MS Registry. Dr. Cohan is a dedicated researcher, the author of 86 peer-reviewed articles, and has made 200 presentations at scientific meetings in the United States, Europe, and Japan. In 2018, he was acknowledged by the National Multiple Sclerosis Society as Medical Practitioner of the Year, and in 2019 was inducted into the National Multiple Sclerosis Society Hall of Fame. At this time, I'd like to hand it over to Dr. Cohan.
Thank you, Dawn. Thank you very, very much. That was a very kind introduction. You heard Dawn say that we started the MS Center in 2001 because it became apparent that really it was needed. That although we had an excellent MS Center at OHSU, they clearly could not possibly take care of the number of patients who needed expert care. So in 2001, we started the MS Center with the hope of having 100 patients by the end of 1 year, and we had 300. And at the end of the second year, we hoped to have 500, we had 700. And each year for a number of years, the number we predicted we would be caring for always shot short of the mark. And as you heard, we now take care of more than 3,000 people in the state of Oregon, and Southern Washington. It's been an extremely gratifying experience. And although the care of patients and their well-being is always the centerpiece and driving force behind what we do, from the very beginning, I recognize the importance for establishing ourselves as a significant research center, because only through research do we make progress in the treatment of this very serious illness. Once we had established the MS Center with a robust patient population, we began to participate in clinical trials. Clinical trials that are multi-centered, international in many cases, that lead to the approval of medications for the treatment of MS. And of the 16 currently approved medications used for MS, we have been principal investigators for all but just a handful. And we're very, very proud of that. But we wanted to do more than that. May I have the next slide, please? That's not me. That's never been me on the left-hand side. So what we wanted to do was we really wanted to establish a robust research program, but we wanted a research program that not only included participation in admittedly very important clinical trials, we wanted to generate research programs of our own, with the eventual hope of also having a preclinical basic research program that also would help drive discovery. May I have the next slide, please? Now, in order to do this, we not only had to develop a strong clinical presence with both physicians, nurses, and those who support us, and a large patient population, we had to build a research infrastructure, and we have. Our infrastructure is so strong that we are frequently cited by various contract research organizations and research monitors as being an outstanding site for the quality of the work that's delivered. And our research coordinators are the people who deserve all that praise. Now, they don't always stick around all the time. Occasionally one leaves us to go to medical school or get a PhD somewhere. So that's how good they are. And we just hope and pray that we make the work interesting enough so that people of this quality will stay with us. Now, we've divided our research, it's now evolved actually, into 3 basic categories. There's clinical therapeutic research. This is the drug development at a clinical level, some of which comes from the outside and some of which we are working on ourselves. And there's also diagnostic research, which I'm going to touch on in a little more detail later, in which we try to improve the ability to diagnose disease activity. And there are a number of projects we've been involved in, and I'll touch upon them. Now, one of the other things that we do is registry research. And we initiated with the founding of the Pacific Northwest MS Registry, but now have a number of other registries, of which I'm going to talk about, and what value they've brought to the table and how good they've been for us. But what we also wanted to do, and now we are doing, is what I'll call translational research. Now, when we talk about translational research, what we mean is that you take basic science, studies in animals, studies in tissue culture or cell cultures, studies in the test tube, and you try to gain information about molecules that potentially could be of use when given to human beings with a given disease. So you do basic research, but you do basic research with the purpose, not of just learning something, but with the purpose of developing a molecule that might be of therapeutic value. So basic research is the foundation of clinical research. Have the next slide, please. So let's start off with our clinical stuff. So as I mentioned to you, we are very involved in therapeutic trials. I just took a little quick look at our list ongoing, and we're currently involved in 42 trials. Some are actively ongoing. A few of them are still in negotiation, where we have to worry about safety issues and legal issues and so on, and get a budget approved by the sponsor. But that's how active we are. And we always seem to have 30 or 40 trials that are ongoing. It's an enormous amount of work. And again, none of this could be done without our extraordinary support team of research coordinators. But again, as I mentioned earlier, we're not just interested in doing multi-center trials developed by somebody else. We want to develop research ourselves. So I'm going to give you an example of a few pieces of research that have come solely from us. Let me start with something we called the BEST trial. Now, back in the early 2000s, we only had 4 medicines that were approved for the treatment of MS, all of which are fairly modest in their efficacy. And if a patient broke through, you were stuck. There was really nothing else you could do. So we knew from some earlier studies that if you could shorten the onset of disease, if you could get control of the disease sooner, earlier in the disease course, the prognosis for the patient would improve. So we did a study in patients receiving beta interferon, one of the foundation disease modifiers in MS. And in half of the people, we added large doses of steroids every month for the first year. The idea being that the combination therapy might give us earlier control of the disease, and compared that to people who just got the routine beta interferon every week that they were supposed to get. And what we found at the end of the first year was that there was a marked decrease in the number of patients having disease activity in the form of new attacks in the patients receiving combination therapy. Now, soon thereafter, high efficacy drugs became available, and the usefulness of this knowledge became less useful, to put it nicely, because we had drugs now that we could go to instead of trying to augment interferon. We also looked at the issue of patients who don't seem to be sick, people whose disease seems to be under control. You have a patient with the relapsing form of multiple sclerosis. They're on a disease-modifying agent, and they have no new attacks, and their examination doesn't change, and they have no symptoms. Is the disease really under control? And what we were able to show is that by doing repeated MRI scans on a scheduled basis, we were able to detect clinically undetectable disease in 1 out of 6 of those patients. In other words, the medication they were on was not sufficient. And if we hadn't been doing frequent MRI scans, we never would have discovered that. Now, one of the other big issues that faces us is how do you transition a patient from one medication to the next? So a very, very fine medication that many of you have heard of called Tysabri sometimes has to be discontinued for reasons of safety. The FDA suggested strongly that if you take a patient off FDA, or take a patient off Tysabri, that you should wait about 3 months for the drug to be completely washed out before you start a new medicine. Well, the problem with that is when you do that, some 30 to 50% of people have relapses within the first 3 to 6 months. And sometimes those relapses are devastating, and many of those patients never recovered their original basic status. So we reasoned that doing a washout was a bad idea, and that we should be able to do a better job in controlling reactivation of disease. So what we did is we had a large cohort of patients who were coming off Tysabri, and instead of doing a washout, we started them on a medication, another medication, the day they would have been due for their next Tysabri infusion. And we used a medicine of rather modest efficacy. We did not use a big-time player. And what we found is a relapse rate that could be anticipated to be in excess of 30% dropped to 4%. And furthermore, not a single patient had a serious relapse, and not a single patient had to be hospitalized. This was work that we designed, it was our idea, and we were very, very pleased with the results. One of our colleagues, Dr. Kyle Smoot, has been very interested in looking at melatonin. Now, many of you have heard of melatonin. You know, you take it for sleep. And it's apparent that at least in some patients with MS, melatonin levels are too low. So Dr. Smoot initiated a trial, which he's the principal investigator for, and we're now examining melatonin treatment of patients with MS. It's a preliminary pilot study, and if the results are promising, we'll go into a larger study. Dr. Smoot has also been interested in trying to reduce the impact of infusion reactions. Sometimes they're serious when patients get certain intravenous medications. And what he has done is he has, I've just lost my screen. Excuse me, everyone. I have to take 1 second break. There's a timer on this, and I just lost everything. So hang in there with me. And let's see if I do this properly. No, it didn't like that. One more time, I promise. Yeah, there we go. Okay, so Dr. Smoot has designed a study, again, where he's the principal investigator, where he's looking at the introduction of agents pre-infusion to see if he can reduce the impact of infusion reactions. We've established an important relationship with the Institute for Systems Biology, among the leading groups in the world in genomic analysis. They are in Seattle, Washington. And we, along with our fellow Providence MS Center in Seattle, Swedish, we are studying now the relationship between deep genomic sequence characteristics and patients' responses to various medications for the treatment of multiple sclerosis to determine whether we can predict who will or will not have a good response to the medication, both from the perspective of therapeutic benefit and also risk. May the next slide, please. Now, I also talked about registries. Now, we started the Pacific Northwest Registry quite simply because we didn't know how many people in Oregon had MS. And we heard estimates all over the place. And we wanted to get a sense of where people live. Were patients rural? Were the patients urban? What access do they have to doctors and so on? The Pacific Northwest Registry has had over 4,000 registrants. And we think that we have registered more than half the people with multiple sclerosis in the state of Oregon and Southern Washington state. We've learned a great deal from this registry. We've learned about access to care. We've learned about the impact of socioeconomic status. We've learned what medicines patients are taking and how it relates to the severity of their disease. We've been able to study the impact of depression on patients' perception of fatigue, fatigue being an enormous impact issue for patients with multiple sclerosis. Tamila Stuchner, one of the people in the registry team, has just had a paper published in a major journal that looks at patients' persistence and adherence on medicine and the impact of switching medications. And these are the kinds of data we've been able to evolve. And we've learned an enormous amount in regards to multiple sclerosis in the Pacific Northwest by creating this entirely voluntary registry in which the patients provide us with a wealth of information that serves as the basis for the research we can do, with the eventual goal of improving patient access to care and improving outcomes. However, we have other registries. This is another topic that Dr. Smoot is very interested in, and he's the lead for 3 of our registries, and I'm just going to talk about 2 of them. I want to talk about the Methyl Fumarate registry. Methyl fumarate is a drug, dimethyl fumarate is a medication. Some of you know it as Tecfidera, which is used very, very common, one of the most commonly prescribed medicines in the world for multiple sclerosis. And when the studies were completed, the investigational trials that led to FDA approval, it was noticed that a small percentage of patients had a persistent, significant drop in their white blood cell count. Now, this is important to us because theoretically that makes patients more vulnerable to infection. And the number that was published was 2% of people had sustained reduction in white blood cell count. The registry that we have shows that it's much higher than that, because in the clinical trials, certain types of patients are excluded. We apply this to all the patient population that's taking this medicine. And what was discovered was that the risk of sustained low white blood cell count, and therefore potential risk, increased several fold over that was originally published. We removed the selection bias of the clinical trials and discovered risk in patients that heretofore had not been appreciated. Now, the S1P modulator registry is just beginning, and I'm not going to dwell on that any further. But the anti-B cell antibody registry, medicine ocrelizumab, there are over 400 patients that have been included in this registry. And what we've discovered is important things, again, about risk. We know the drug's effective. That's not new news. But risk is important. These are very efficacious drugs, but carry risk profiles, especially for infection. And we've gained very important information as a result of having our own independent registry, which is large and which is not influenced in any way by the pharmaceutical industry. It's our registry. We control it, and we decide what to look for. Now, our most recent registry is the National African Americans with MS Registry, which was launched in September 1st of this year. It comes as no secret to anyone that African Americans are underserved medically, irrespective of what disease they have. And it's certainly true in the case of multiple sclerosis. So over the last few years, as we've seen glaring examples of murders, mistreatment, lack of equal access to our society, we began to ask ourselves what we could do as multiple sclerosis neurologists to make some meaningful contribution to rectifying these inequities and this injustice. And as neurologists, taking care of people with multiple sclerosis who have experience and expertise in registries, we decided to establish a national registry for African Americans with multiple sclerosis. And we worked on it for 3.5 years. It's not something we did alone. We were very fortunate in having 3 very, very prominent African American multiple sclerosis neurologists, 2 in Texas and 1 in Georgia, and recently have been joined by a 4th who is currently in North Carolina at Duke University. Our purposes were to develop a large number of African American patients with MS to address the following kinds of issues. Since 1960, there have been 60,000 publications approximately in the English language about multiple sclerosis. Fewer than 100 of those publications addressed MS issues as a focus in African Americans. So what we know about African Americans and multiple sclerosis is mostly conjecture and so-called expert opinion, or small observations in a few people, just a setup for selection bias or worse. So we really don't know whether African American people do better or do worse, are more vulnerable or less vulnerable to side effects, and so on and so forth. This cannot continue. Secondly, although African American people comprise 13.5% of our population, on average, they comprise less than 1% of the participants in clinical trials of new medicines in multiple sclerosis. Their numbers are so small that we cannot, with any of this data, determine whether their response to the medication is different than their Caucasian counterparts. Again, something that's simply not acceptable. What do we know about access to care? What is the difference between a person living in a southern rural town with MS and living in Chicago or New York or Portland, Oregon? What about the impact of socioeconomic status? What about the impact of comorbidities like obesity and cigarette smoking and diabetes mellitus, all things we know that plague the African American community? There are no answers to any of these questions. So we are determined to create a cohort of patients who are African American and have multiple sclerosis to try to rectify these deficiencies, to learn about the disease in them, to learn about how they respond to medication, and to provide an opportunity for them, if they so choose, to participate in clinical trials by informing them what clinical trials are going on and who they have to contact to participate. Knowledge is power. And we also believe, it's pretty high likelihood, that African American people with MS as a group do not have access to as much information, again, as Caucasian patients with multiple sclerosis. So as part of our registry, we are going to have an educational newsletter that deals with such subjects like what is MS, what medicines are used to treat MS, what are the symptoms of MS, what lifestyle changes should you make and what their impact is on the disease, and so on. This is a big undertaking. We actually hope to enroll 20 to 30,000 African Americans across the United States, North and South, rural and urban, East and West, to finally answer the questions that these folks deserve to have answered. May I have the next slide, please? But we also are interested in translational research. So now I want to tell you a little story. It's been known for quite some time now that women with multiple sclerosis have a reduction in disease activity while they're pregnant. And then soon after the baby's born, 4 weeks, 6 weeks, 8 weeks, disease activity returns. Well, that's interesting. And people understandably said, well, this must be due to hormones that are produced during pregnancy, increased progesterone, increase in various estrogen compounds. That must be the explanation. So studies have been done in women who have multiple sclerosis, and unfortunately, hormone therapy of the progestational or estrogenic groups have really been of no value, significant value. There's got to be another explanation. Well, it turns out that there's a hormone called relaxin, it's a protein, and its concentration goes way up in the blood of women when they're pregnant. What does relaxin do? Well, it relaxes the uterus so that the uterus can accommodate an ever-enlarging baby, and then relaxes the cervix. One of my daughters is an obstetrician. I hope I get this right. It relaxes the cervix to permit birth. That's how it got the name relaxin. Well, it turns out that relaxin is not just that. It turns out that relaxin interacts and regulates a number of genes that control the immune system, and the genes it regulates tend to have tolerogenic effects. What that means is it reduces the immune response. Is it possible that this elevation in relaxin during pregnancy helps reduce MS disease activity during pregnancy? That seed became the beginning of the idea for our project of using relaxin as a therapeutic agent in patients with MS. But this would be a new application, and the FDA would not allow us to use it in humans, understandably, until we had some basic science data that spoke to potential efficacy, that it was worth doing. And we were stuck on hold. We didn't have a laboratory, we didn't have animals, and we had no money. And with the help of the foundation, we were able, in a very short period of time, and some of you contributed to this, we were able to raise a very significant amount of money, and thus started our translational research program. We were also very, very fortunate in that Dr. Keith Wegman, a PhD immunologist and expert in animal models of MS called EAE, partnered in the project. And then through the good offices of the Cancer Center and Dr. Walter Erba and Bernard Fox, we had access to the vivarium where they keep the animals, and we established a mouse colony that Dr. Wegman converted into the animal model of MS. And we started using relaxin. Well, what we discovered was that the animals seemed to respond. The EAE sort of calmed down, but the response wasn't that robust, and it didn't last very long, and then they lost it. And it took a while to figure that one out. And we thought we understood it, that the problem seemed to be that relaxin was broken down so quickly by enzymes in the mouse that there was none there. That's okay in a female who's pregnant because she's producing it all the time, but it's not okay if you're injecting a mouse once every 24 hours. So we needed a solution to this problem, and we established a relationship with some researchers at the University of Florida who had a new synthetic molecule that mimicked relaxin, but was more potent and lasted for many, many, many hours, called ML290. And we established this working relationship with us, and they provided us with the medication. So we used it. And it turned out that it wasn't working as well as we thought. When we compared our responses to the work the folks at University of Florida were doing in diabetes, using human cells, we weren't getting the kind of response we thought of. Now, I want to take a pause for a moment and sort of create a model for you to think about. I'd like you to think of a drug or a chemical as a key, and a receptor for that drug on the surface of a cell as a keyhole. Now, if there's a fit, you can turn the key, you open the lock, the door opens, i.e. the cell, and you can enter the cell. But if the key isn't such a good fit, well, you may jiggle it around and jiggle it around and jiggle it around, and eventually it catches and the door opens sometimes. Well, that's sort of the situation we found ourselves in with ML290 with the mice. We then discovered that the mouse receptor for relaxin was different than the human receptor. Why shouldn't it be? It's a different species. And through our connection to the University of Florida, we found out that someone had bred a mouse that expressed the human relaxin receptor, a transgenic mouse. So that's the animal we now use. We now use a transgenic mouse. Several animals were donated to us, out of which we built a colony of transgenic mice that express the human receptor, and they are currently the subjects of research using ML290 in EAE to see if we can cure EAE and thus to raise the plausibility that relaxin-acting molecules are a therapeutic agent for the treatment of multiple sclerosis. As a result of this work, we actually became known to and established a relationship with two other laboratories. One is called NCATS, that's the National Center for Advanced Translational Science. And the second laboratory was the Laboratory for Molecular Signaling at the National Institutes of Alcohol Abuse and Alcoholism. And they approached us and said, you know, we're really very interested in what you're doing, and we'd like to know if you'd like to work with us. We have molecules we'd like to test that we think are of potential value. But the problem we run into all the time is we develop a molecule, and then people like you say, yeah, we're really interested in testing it, but then they don't have a way of testing it. And I understand that you have resources and you have a vivarium and you have animals. Would you be willing to work with us? We said, well, of course we would. And the molecule that we settled on was something called Synaptomide, which is a molecule that's produced by the body. This is not a synthesized molecule. And it turns out that Synaptomide turns off the genes in the white blood cells that drive inflammatory reactions. And it's a molecule of great interest to us. Now, I want to back up a little bit. If we hadn't received the generous support that allowed us to develop our animal laboratory and begin the relaxin research, there would have been no basis ever for establishing these other relationships with the University of Florida and with the NIH. And now we have a very strong cooperative relationship in which they will be providing us with molecules that we'll be able to examine in our test systems. Now, our test systems are going to expand because we want to do more than just demonstrate that an animal may do better on a chemical that we are administering. We have to dive deeper, more deeply into the science behind it. We need advanced microscopy. We need advanced fluorescent and fluorescent stain indicators so we can know which cells we're looking at in a tissue slice and so on. Deeper molecular analysis and genetic analysis of the impact of these chemicals on the genetic presentation within the animals. So our research is going to get a lot more expensive as we move forward, but we're very, very excited about this. I want to tell you about, I just lost my screen again, folks, I'm sorry. I'm going to try to get this fixed as quickly as I can. See, there's a timer on this, at least on mine. And what happens is past a certain time, the timer goes off. All right, so I want to tell you about our relationship with Dr. Jim Connor at Penn State. Dr. Connor is a very well-known biologist who for many years has studied the impact of iron on cell survival under stress. And as a result of his work in one of his animal models, he discovered that a molecule called semaphorin A was upregulated. It went way up. And he furthermore discovered in tissue culture that if he dripped on semaphorin A, it actually killed nerve cells. And he got to wondering whether or not semaphorin A might actually be one of the things that is responsible for cell death under injury, such as inflammation. So he went to a young neurologist at Penn State and asked her if he could get some spinal fluids for some patients from with MS. She provided him with samples from just 4 patients. And in every patient, the semaphorin level was very much elevated. Now, this is very interesting because there's a couple different issues here. Number one, if semaphorin A is upregulated, could it be used as a biomarker of disease activity? Could you detect disease that was ongoing, even though patients' symptoms weren't changing, and intervene sooner? Secondly, if semaphorin A is contributing to the damage, could you develop molecules which block semaphorin A, which may be therapeutic? Those were the questions. And we now have a working, ongoing relationship with Professor Connor at Penn State, where we're going to look for semaphorin A in the brains, spinal cords, and blood of our EAE animals, and also be able to study the effect of synaptomide and ML290 on semaphorin 4A production. But we're also doing it in humans, translational research. We are in the process now of starting a protocol where patients with acute MS attacks, patients with MS who are stable, and people who don't have MS but need a spinal tap for another reason, we will be looking at the spinal fluid and blood to see whether or not we can measure semaphorin 4A and whether or not elevations in semaphorin 4A will be duplicated in humans in such a way that we can use it as a biomarker. And if our animal studies also show that it increases disease activity, could we develop a molecule that blocks synaptomide, perhaps blocking the synaptomide receptor, for instance, with an antibody? That would be a new therapeutic agent. All right, none of this would have been possible without the very generous, I don't want to use the word seed money because it was a lot more than that got us started into all of this. And this is a very big part of our future. Next slide, please. All right. What else are we doing? We're doing a lot, I know, but we want to do more. So one of the things that's very important is to try to improve MRI contribution to patient management. We know that MRI lesions may change in size so subtly that even the most experienced and careful neuroradiologist cannot detect the difference. Well, there are now computer models that enable very precise lesion volume quantification, requiring special software. Again, because of an extraordinarily generous contribution to a member of our family, from a member of our family, we are putting this on board, and we will be able to detect disease activity and thus the utility of the medications patients are on at a level never before possible. We are participating in the Genome for Me, and this is a Providence system-wide project in which a group of geneticists in Los Angeles who are Providence physicians will be doing deep genomic analysis of our MS patients to determine, one, if we can predict who has the most serious course facing them. Two, can we predict how they will respond to medication? And three, what other illnesses may they get because of the genomic profile that they otherwise had no suspicion of getting, that this deep genomic analysis will yield data to help us guide them and to counsel them on how they take care of themselves in the future. So I'm going to stop there. That's all I'm going to talk about, except now I want to show you the next slide. These are the people who make this possible. And I left somebody's name off, and I'm going to get into serious trouble for it, I know. And that was Leah Gedicke is a nurse practitioner who was part of the heart and soul of the clinical MS program, and I cannot leave her out. I want to call out a few names in particular, especially Chai Chen, who's an RN PhD and an expert in outcomes research. She has done, we've been working together now, I don't even know how many years, 10, 15 years now. Time has flown. And I know how little I would have gotten done without her. She really is, makes sure that all the pieces are in place for all the research we do. She helped develop our research coordinator program. She helps us with budgeting. She helps us with regulatory. She helps us with our writing. And of course, she's a very, very smart person. So her intellectual currency has been a gigantic contribution to what we do. Keith Wegman, as I mentioned earlier, is the PhD immunologist who really is running the animal studies. You know, when I say I mean we. And when I say we, I probably mean them. This is an enormous joint effort. Elizabeth Barabin, who's head of all of the registries, not just ours, and Tamala Stuchner, who has selflessly given of herself to make sure these registries are a reality. Her contribution to getting the African American registry off the ground, I cannot overemphasize the contribution she's made. Lois Grody, who is an RN, who is an expert on abstracting clinical data from charts. And then there's a long list of names of people. These are our coordinators and regulatory folks, and they are simply outstanding. And they make us what we are if we are successful investigators. Next slide, please. Okay. So this is just an update, a summary, if you will. We want to take care of patients, and we want to take care of patients the best way possible, using all the resources that are available to us to do so. And we believe very strongly that clinical care and research are partners. That clinical research of high quality, that's productive, always leads to better patient care. And our contribution to this effort takes three forms: our clinical research, our registry research, and now, very importantly, our preclinical translational research. Our future research efforts, and we're not going to stop doing clinical research, we promise, but we intend to use our resources to further expand our basic research contribution to translational work so that we may envision new and better therapeutics for people with multiple sclerosis. I think that's the last slide, isn't it? I was right. Questions, everybody?
Well, thanks, Dr. Cohan. Yeah, we've got, so just a reminder for everyone who's on the call right now, if you have a question and you don't see where the Q&A tab is, you move your cursor down to the middle of the screen and you'll see a Q&A box. So go ahead and click on that. So Dr. Cohan, you ready for some questions? You've had a sip of water, I assume. Our first question. Oh, it's coffee. Okay, good. You're caffeinated. I like it. Okay, so our first question is, just like cancer has personalized medicine, do you anticipate that one day MS may have the same therapies that can be targeted?
That's an excellent question, and the answer is yes, yes, yes. That's exactly where we're going. That's why the genomic research is so important. Because if we can put people in various genetic categories, just as you put cancers in various genetic categories, you can design therapies that you know by prior research are more or less effective for those different profiles. There has been something called GWAS, which is an enormous genomic project that went on worldwide that has demonstrated over 200 genes that influence MS activity and risk. The problem with the data is not applicable to an individual patient. So what we need is patient by patient, individual genomic profiling, and that's what we're doing with our MS population. That's a great question. Thank you.
We had another question that said, is there a way to check if I'm on the Pacific Northwest Registry?
Aha! Only if you signed up. So we're going to send everybody a little notice on how to get onto it, because I don't have it in front of me. And anyone who wants to join the registry, we're going to send out, Dawn, you're going to have to do this for me. We're going to send out a blanket announcement to everyone who's on this call. It won't be relevant to everyone, I understand. But to the extent that it is, it will tell you how to join the registry. And I strongly encourage every patient who has MS, please join that registry.
Okay, I got another question and I'm happy to do that. I'll include that in our follow-up email.
Notice how easy it is for me to give other people work to do.
I just got a question. How can we participate in the genomic research?
Well, if you are a multiple sclerosis patient and you are being cared for in our MS center, you are automatically going to get approached to participate.
Oh, good, 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 good.
And we'll only do so with your permission. We would never do this without your written permission.
All right, and it looks like another question I got on email. When will the MRI tracking program begin?
Well, the problem we have there is actually COVID. What happened to us was engineering has got to be done to our computer systems to put the data into the computer that analyzes the MRI scans. And we were all set to go. Our IT engineers are just wonderful. And then COVID came along and everything had to be changed. And so much is now being done online that we had to be understandably moved down in the queue a bit. But so I can't give you a firm answer, but everyone recognizes the importance of this project. Everyone understands it's a very high priority project for Providence, and we hope to be starting very soon. I know that's a vague answer, but at least you understand why we haven't started yet.
All right, let's see. We don't have any other questions. I want to make sure I give us just a few more seconds in case any last minute burning questions come in. Just a reminder, if you do have questions after today's presentation, you're welcome to email them. Oh, looks like we got another question. Email them to me at the email address you saw. You'll be getting an email from me with the recording, so you can respond to that as well. All right, it says, for people who do not have MS diagnosis but have symptoms that mimic MS, no lesions identified on MRI, is there another way to test?
Good question. So there are what we call multiple sclerosis mimics, and there's a fairly long list of diseases that can produce symptoms like multiple sclerosis. However, it's not MS. And by today's standards, in the absence of lesions on MRI scan, one cannot make the diagnosis of MS. But there are other inflammatory diseases, for instance, that attack the nervous system that can mimic MS, as well as a variety of non-inflammatory diseases. So one approach to this would be to try to get a referral to an MS neurologist, even though it's not MS, because we're typically the ones who have to look for the other explanations. And your primary care physician can work, with one of the MS neurologists to set that up.
Okay, thank you. We have another question. Is the MS Center involved in research investigating how to repair damaged neurons?
Yes. So there's an investigational trial. It's called Radius, and we've actually fully enrolled in that study. Take a few moments to talk about it. The molecule is called elezanumab. The MABs will rule. It's amazing. By the way, MAB at the end of everything, including what you see on television for arthritis, it stands for monoclonal antibody. UMAB means humanized monoclonal antibody. Okay, so elezanumab is very, very interesting. So I want to tell you a little side story. There is something called guidance molecules. So there's an embryo with a cell that has to connect to another part of the body. How does it know to go to the place it's supposed to connect to? Well, we make guidance molecules that direct the cell to go to the right place. So let's take the nervous system. A cell is developed in a portion of the brain called the brainstem, and it's going to be a visual fiber. It's got to make its way to the retina of the eye, but it has to go to the right place. How does it get there? Well, it turns out that during development, there are these molecules that make it grow in the right direction in a very precise way, and those are called guidance molecules. Ironically, once you are born and once you're an adult, those very same molecules prevent nerves from growing. So it was reasoned that if you could block these guidance molecules in a damaged adult brain or optic nerve, you might get regrowth of the nerve to the right place. And in animals, that's precisely what has been seen. So now what we are doing is we are currently testing a monoclonal antibody that blocks what are called repulsive guidance molecules, which in tissue culture and in whole animals has resulted in nerve regeneration. And we are currently evaluating this in a very, very large project that involves patients with several different types of multiple sclerosis, both progressive and patients with relapsing. Because although we may be able to stop the progression of the disease in many, many, many patients, what do you do about the damage that's been left in its wake? Mm-hmm. And that's what these studies are about. And there are other studies as well, looking at other molecules that may promote remyelination, for instance. And that's ongoing as well. So we are very, very focused on this topic without question. And it is going to be one of the centerpieces of future research.
Thank you. We have a question, how do we donate to research? I'm happy to answer that. If you're interested in making a gift to Dr. Cohan and his team's research, please feel free to email me or respond to the email that you get from me. Amy wants to know, will the new MRI technology enable you to identify patients that are candidates to discontinue their medication because of disease inactivity over the course of several years?
stop their medicine because of disease inactivity? Okay, that's a burning question in neurology. There are some people who argue that, well, after a person's had, especially a person who's older, who's had disease for many years, the immune system's not as active in older people, so maybe they don't need medication. And there's a study going on right now, headed out of University of Colorado by Dr. John Carboy, trying to answer that question. We know of no evidence that taking patients off medicine is safe. On the other hand, we have patients who are older who have not been on medication for years and the disease hasn't progressed. So it remains an open question. It's a very good one. I think that if it is possible to get people off, having more precise MRI measurements as reassurance that the disease is not active may be useful, along with, by the way, some of those blood biomarkers I was talking about. If they show no activity and a very precise quantitative MRI shows no activity, and there is evidence that you can take patients off medicines, yes, it might assist in that decision.
Okay, thank you. I have a question that I think is kind of related to that, Dr. Cohan. Janice wants to know, will you ever involve patients who are over 65 in research studies? It says we're always left out of studies.
The answer is yes, and you're absolutely right. Remember I said earlier that several of Dr. Smoot's registry studies had demonstrated risk issues that were not demonstrated in the clinical trials because there was a bias against older patients. Any patient, first of all, I don't believe in age. That's because I'm so old. No, I don't believe in age. It's not how old you are, it's how healthy you are. And that should be the determinant of what you have to gain from therapy. And so therefore, age is a bias that's too much a part of our society. So when we do studies, if we're in control of the studies, and age should not be a factor, it won't be a factor, I promise you.
We have a really timely, relevant question here, Dr. Cohan, that I think is going to be useful to the participants who have MS. Has the COVID-19 vaccine been tested on patients with MS, and are there concerns with taking the vaccine?
That's an extremely important question. First of all, we have not been made privy to the patients selected for the studies, so I can't answer the first part of the question. However, let me launch into a little further discourse on COVID and MS, because clearly every person with MS wants to know this. There now have been several very large studies published. One from Italy, superb study, an excellent study from France, and a smaller but excellent study from the Netherlands. What they have all shown is that there's no evidence to suggest that people with multiple sclerosis are more vulnerable to getting infected with the COVID virus. That's the first point. The second point is that there is no evidence that patients who have MS who get COVID infections fare any worse than people who don't have MS who get COVID infections. And that's from the perspective of death rate, ICU admissions, length of hospital stay, or even hospitalizations. So right now, there is no evidence that MS patients represent a selectively vulnerable population at all. Now, as far as the vaccine goes, if I have to inject it into you myself, I will. It would be a serious mistake not to get inoculated. So far, we know that 2 of the vaccines that are almost certainly going to be approved very quickly by the FDA are extremely effective, probably the most effective vaccines we've ever seen, or maybe comparable to measles and smallpox, vaccines like that. Furthermore, so far, they've had an excellent safety profile. The number of people who've been injected in studies probably is between 60 and 70,000 people over a wide range of ages. You may have seen on television yesterday the announcement, for instance, that age did not influence efficacy of response. So we know older people have received this vaccine and have done safely. There is no reason to think that the upregulation of your immune system will make your MS worse, no more than the upregulation of your immune system by a flu shot makes your MS worse. That's an old fantasy fable that flu injections make MS work. Now, I may be wrong, but certainly there's no evidence at this point, nor should there be a reason. for the upregulation of a small segment of the immune system that's devoted to attacking COVID virus spike protein should then turn around and attack your nervous system. They are molecularly very unrelated. Please get the injections when you have availability to get them.
Thank you. We have another question that's related to COVID. National MS has listed 4 drugs that they feel will raise the risk factors for being infected with COVID-19. Can you speak to that?
Well, that's all theoretical. It's all theoretical. What they're talking about are medications that lower the lymphocyte count. Ocrevus, Mayzent, Zeposia, ofatumumab, Gilenya. These are all medicines that lower lymphocyte counts. Where that's an issue, theoretically, I don't think has to do with COVID vulnerability, because by now we would have seen that, because those are among the most widely prescribed medication in MS populations in the world. Where there's an issue with some of these medicines is that the immune response to the COVID vaccine may not be as robust as people on some other medicines, but that's a theoretical consideration. And we'll only know that after we start using the vaccine and can start measuring the height of the immune response in people on those medicines.
Thank you. We have a couple more. I'm going to try to be sensitive with time. Is spinal pacemaker a treatment that can help with MS symptoms?
No, and I shouldn't say no. Patients with spasticity and patients who have pain syndromes have been treated with stimulators. I have some patients who feel they've responded, but by and large, and this is my personal view, okay, remember that, it's my personal view, I think they've been very disappointing. Furthermore, once they're implanted, you can't do MRI scanning. And that's a tremendous barrier to the care of people with MS. So I would strongly recommend that people with multiple sclerosis do not get implantable devices that aren't critical. Obviously, if you need a cardiac pacemaker, you get the cardiac pacemaker, but I would not use it for pain management or spasticity management.
Thank you. Will the MRI lesion evaluations only be done on new MRIs, or will you be looking at prior MRIs for existing patients?
I love that question. We can go back to old MRIs. So we'll have it online and someone goes in and gets an MRI, we analyze them. And we want to see if there's change over time. No, we don't have to wait another year for the next MRI scan. We can go back to their past 2 or 3 or 4 MRI scans over the last 3 or 4 years and see whether the disease has been controlled, because these computer programs allow us to go back to the old MRI scans and do what's called post-acquisition processing and analyze the old MRI scans for the size and the volume of the lesions and compare them to the current MRI scans. And actually what we're hoping is that with some of the therapeutic agents, maybe the lesions get smaller and it hasn't been detectable before, as additional evidence that the medication is working.
Thank you. Well, thank you, Dr. Cohan, for your time today. And thanks to all of you for your interest in this important work. Just a quick kind of as we close, Dr. Cohan wanted me to encourage you to participate in clinical trials when it's appropriate. Participate in registries when it's appropriate for you, and participate in philanthropy. Many of our patients have chosen to express their gratitude for their care by making a charitable gift in support of the MS Center's initiative. As Dr. Cohan mentioned, his team depends on the generosity of our community to fund their MS Center-driven research. If you're moved to express your gratitude with a gift to the MS research efforts, or if you have questions about today's presentation, let's talk. My email address is, as you saw many times already, and you'll get an email from me following this up with the recording of today. And just a reminder to look for that email. It's going to have the program in it probably around Friday, and feel free to share it with your family and friends. Thank you again for participating today, and we hope you have a wonderful afternoon.